I've been given the daunting task of presenting high-impact cardiology clinical trials over the last 12 months. And the reason this is challenging is because there is such a high volume of quality cardiology papers published every week, much less over the course of a year. And so to distill that down into 30 minutes is going to be problematic, but I'll do my best. So as I said, I think it's impossible to cover everything over the last 12 months, but I'm going to try and include something for everyone. I'm going to discuss the BRIDGE trial because I think that's a study that really does influence our practice on a daily basis and looks at the role of interrupting warfarin for planned procedures. As an interventional cardiologist, I'll discuss the TOTAL study briefly, something for the interventional cardiologists in the audience. And I'll talk briefly about the two studies that have been published recently looking at PCSK9 inhibition in lipid lowering. And I think that this is a really exciting and new set of agents looking at patients who are either intolerant of statins or treating that residual risk that we know persists despite aggressive statin therapy. So as I said, starting with the BRIDGE study, that was looking at the role of perioperative bridging anticoagulation in patients with atrial fibrillation who would undergo planned elective procedures. And it's been a bit unclear as to the role of bridging in these patients, whether the best thing to do is to discontinue warfarin or whether the best thing is to bridge these patients with either intravenous heparin or, in this study, subcutaneous dalteparin. The hypothesis is that by avoiding bridging with the subcutaneous agents, that we don't have a penalty in terms of thromboembolic complications, but we actually have less bleeding. And this has certainly been borne out in the antiplatelet realm also. So patients that have undergone previous percutaneous coronary intervention who have been on dual antiplatelet agents, when those patients have their antiplatelet therapy discontinued and commenced on subcutaneous agents, their risk of bleeding is higher. And so this study is to look at that in atrial fibrillation. So I apologise, this is a very busy slide. But this was a randomised double-blind placebo trial that enrolled patients with long-standing atrial fibrillation who had been on warfarin for more than 3 months with acceptable INR levels and were undergoing elective operation or invasive procedure. And so the vast majority of these, when one looks at the appendix, I believe, are orthopaedic procedures. But I think it's certainly important from a cardiology perspective, as we have many patients who undergo invasive procedures, whether they be cardiac catheterisation, pacemaker implantation, and so on. And all of the patients enrolled in this study had to have at least one risk factor on the CHADS risk score. And I actually think this is quite important in terms of the risk profile of the patients enrolled in this study, and that's something that I'll come to. Patients were excluded if they had underlying mechanical heart valve, if they had recent stroke or systemic thromboembolism or major bleeding, as well as the laboratory parameters as outlined. And I think that's reasonable in terms of having an appropriate inclusion criteria. Now, in terms of the baseline characteristics, they were very similar amongst the two groups. But the one thing that I would like to highlight is that this was a relatively low to moderate risk group of patients. The vast majority of patients in this study had a CHAD score of between 1 and 3, and patients with a higher CHAD score of 5 and 6 were very seldom represented in this study. Similarly, when you look at the baseline characteristics and what made up that CHADS risk factor score, if you like, is that there were very few patients enrolled who had had a previous stroke or episode of transient cerebral ischemia. And certainly in my own clinical practice, the patients for which I have the greatest concern about when I discontinue their warfarin are patients that have had a previous thromboembolic stroke complicating their atrial fibrillation. Of note, there was also a very small percentage of patients with mitral stenosis. And I know that may not be particularly relevant in parts of Australia, but it is certainly relevant in parts of remote Australia and certainly in developing countries as well. The other thing that I found quite pleasing about this study is it was clearly contemporary in that we have a number of patients who have coexisting coronary artery or cerebrovascular disease who are also on aspirin. And so I think having a third of the patients on aspirin reinforces that this is probably a contemporary clinical cohort and therefore applicable to our day-to-day practice. One thing I guess that's a little bit different to our experience in Australia is that we don't routinely use dolteparin. We use enoxaparin much more commonly in Australia, but I imagine they'd be very similar. And so patients were assigned to either dolteparin subcutaneously, having discontinued their warfarin 3 days prior to the procedure, or to receive no bridging therapy. Of note, the decision to reintroduce the immediately after the procedure, the patients will recommence on their subcutaneous therapy at the discretion of the treating team, which was continued until the INR was in the therapeutic range. This was a relatively short-term study in that most of the study outcomes were assessed within the first month, with the major primary efficacy outcome looking at arterial thromboembolic complications, including stroke or TIA, with the major safety outcome looking at major bleeding. And there were similarly secondary efficacy outcomes and safety outcomes, as you can see on the slide. And so these are the key results. When one looks at arterial thromboembolism and the various subcomponents of that outcome, there was no difference between the two strategies. Although I guess as one would expect, the risk of major bleeding was significantly reduced in those patients who did not receive bridging anticoagulation with subcutaneous dolteparin. And similarly, as one would expect, there was an improvement in terms of minor bleeding as well, but again without a penalty in terms of the clinical outcomes, if you like. So again, no difference in terms of death, myocardial infarction, deep venous thrombosis, etc. And so the conclusions or the summary from this study is that discontinuing warfarin doesn't seem to impose a penalty on our patients in terms of thromboembolic complications and actually avoids the bleeding complications associated with subcutaneous therapy. And certainly when you look at the combination of bleeding versus thromboembolic complication, there was a clear benefit to avoiding bridging anticoagulation. From a personal perspective, I think this reinforces certainly my current clinical practice and the majority of my colleagues at our institution where I work. Having said that, I think that this reinforces that for low-risk patients. As I said, there were very few high-risk patients enrolled. There were very few patients that had a previous stroke, and they're the patients in whom I think there are still unanswered questions. Interesting, when one looks at cardiac catheterisation at our institution, we tend to continue anticoagulation and proceed with catheterisation performed on warfarin via the radial approach. And so again, that's not immediately applicable to our practice. And certainly I know that my pacemaker inserting colleagues are quite happy to insert pacemakers and devices on warfarin. And so again, this doesn't necessarily apply to people who are comfortable proceeding in that way. This doesn't address the issue of what to do with the novel anticoagulants. I would imagine that as our experience evolves, it will be a very similar approach, that we discontinue these agents 2 to 3 days beforehand and then restart them immediately once hemostasis is achieved. But I still think the unanswered question from this study is what do we do in high-risk patients for thromboembolic complications, in particular those who have a previous stroke. And I think that this is going to be a group of patients that we're going to have to individualise our therapy, looking at their risk of bleeding, as well as their risk of thromboembolic complications. Just to turn our attention now to invasive cardiology, and I apologise for those to whom this doesn't apply. I felt I had to include this, one, because I'm an interventional cardiologist, and secondly, because the senior author on this paper, a gentleman called Vlad Zavik, was a mentor of mine when I spent time in Canada as a fellow. So I felt obliged to include it in the studies presented today. Now, the rationale for this study is in that patients who have an acute myocardial infarction, who undergo primary percutaneous coronary intervention, will often have high burden of thrombus within the coronary artery. And there was a study published a couple of years ago called the TAPIS study that demonstrated a survival benefit for routine use of an aspiration catheter. And what that means is that once we pass a wire past the obstruction, we put down a catheter designed to remove the thrombus burden. And based on a single centre study, this evolved into widespread clinical practice. And it's interesting that this hadn't been replicated in preceding studies or in short, small studies following. And so the question was still unclear, hence the large randomised study that I'm about to talk about. So this was a study that randomised patients with ST elevation myocardial infarction who underwent primary percutaneous coronary intervention to either thrombectomy or routine care. And at 180 days, there was no difference in the principal outcome, which was a combination of death or major cardiovascular events. Although of note, the patients who underwent thrombectomy, which as I said had evolved to standard care, had a higher incidence of stroke at 30 days. These are the graphs that outline the primary outcome as well as the risk of stroke during the course of follow-up over that 6 months, showing quite clearly that there didn't seem to be any benefit to routine use of thromboaspiration. But as I said, there seemed to be a penalty in terms of the risk of stroke, which remains unexplained. One would have thought intuitively that perhaps in those patients enrolled in the study that had a high thrombus burden, that perhaps they would have done better with thrombus aspiration. But as you can see in this slide, that wasn't the case. And so again, we're left with this question of why was there initially a benefit noted in that single centre study? This is just to illustrate that it doesn't matter which way you look at the data, doesn't matter which endpoint you look at, there was clearly no benefit to the routine use of an aspiration device. So the conclusion was that in patients who underwent ST elevation myocardial infarction therapy with primary PCI, there was no difference between the use of manual thrombectomy versus not. And in fact, there appeared to be an increased risk of stroke, which, as I said, remains unexplained. From a personal perspective, I find this study in some ways reassuring in that I've been quite selective in my own use of manual thromboaspiration. I've tended to use it in patients with high thrombus burden, although looking at this study, one could argue that there probably is not a role for that. One of my experienced colleagues is a firm believer in thrombus aspiration. He thinks we've had less slow flow and less no reflow and better outcomes with thrombus aspiration. And so I think there is going to be an ongoing role. I don't think that this study is going to see the end of thrombus aspiration, but I think certainly reassures myself that we don't need to use it in all cases. The other thing is that even though they're relatively straightforward to use, they still incur an expense. And so I think the ability to avoid using an expensive device in every case certainly has potential advantages as well. I still think that this will have an ongoing role in certain cases, but I acknowledge that there is certainly a lack of compelling data in this area. Now, the last thing I'd like to talk about is some of the newer agents that have become available for the treatment of dyslipidemia, and in particular the PCSK9 inhibitors. So these are subcutaneous agents injected every 2 to 4 weeks that were mentioned in one of Dr. Weir's talks yesterday, designed to reduce LDL cholesterol further. And so there have been 2 recently published studies looking at this. Alirocumab, which is which is an agent that we've actually been involved in the John Hunter Hospital with their clinical studies, and another agent that I'll mention in a subsequent slide. So we've been involved in a number of studies in the Odyssey study program, and there will be a series of studies published in this area over the coming years. We've looked at patients who have been intolerant to statin therapy, which is a not insignificant proportion of our patients. We've been involved in intravascular ultrasound studies, looking at whether these agents reduce plaque burden over the course of 2 years. In a similar way to high-dose rosuvastatin and atorvastatin, demonstrating a degree of plaque reduction when examined with intravascular ultrasound. And these agents have been extensively studied in patients with homozygous familial hypercholesterolemia. So in the randomised study of this agent, compared to placebo, there was an impressive reduction in LDL cholesterol over the course of the study period. And in fact, when they look at the adverse events or clinical events, there seemed to be a suggestion of benefit. And again, that's something that I will come to in further detail. But I think this study shows quite clearly a very rapid onset and sustained improvement in the LDL cholesterol levels, achieving LDL cholesterols of 1.25 to 1.5 litre over the study period of 78 weeks. Whilst the investigators of this study are always blinded to the results, patients will often see their family doctor and get their cholesterol levels performed outside of the clinical trial setting. And it's quite impressive that it's very easy to tell which patients got the placebo and which patients were given the active agent. Because certainly my limited experience was that patients did achieve a tremendous improvement in their LDL cholesterol above baseline statin therapy. Now, I think this is very exciting when we look at these agents. So these studies were clearly not powered for clinical endpoints. And when one looks at the Improve It trial that was published during the year looking at ezetimibe in addition to simvastatin, that study was followed for 7 years to demonstrate a relatively small clinical advantage. And so I think when one sees even a small clinical advantage after 78 weeks, that's extremely encouraging. The other thing worth noting, however, is one of the key difficulties we have in maintaining patients on high-dose aggressive statin therapy is the presence of myalgia. And of note, there was an increased incidence of myalgia in the patients on the study drug. So whether there seems to be some sort of increased risk when combining these agents, I guess remains to be seen, but I suspect that may well represent one of the clinical limitations of this agent. And so the conclusions were that when added to statin therapy, that these agents improved LDL cholesterol levels quite markedly, and that admittedly this study was not powered for clinical endpoints, but there did seem to be a reduction in the rate of cardiovascular events with this agent. And just to show that similar results were achieved with its sister drug, evolocumab, which is a very similarly acting agent, there was a similar improvement in terms of lipid levels over the course of the assessment. Now, as I said, from a personal perspective, I find this data very exciting. I think that we've had statin therapy for a long time now. We know that those agents are exceptional at reducing LDL cholesterol, but our patients still remain at residual risk for further events. I think the ezetimibe story over the last 12 months is reassuring that we can further reduce that by further lowering LDL cholesterol, and that these agents may add to that. When we look at residual risk, the other agents that have been trialled, looking specifically at HDL cholesterol as a target, the idea being to increase HDL levels, they've been uniformly disappointing. And so I think looking at agents that increase HDL cholesterol are not going to be the answer in addressing this issue of residual risk. It certainly seems that these agents are well tolerated. I must say my fear when we initially enrolled patients in this study was that patients would not be very keen, that patients would not like the idea of regular subcutaneous injections. But I was pleasantly surprised in that when patients were initially approached about being asked to be involved in the study, that this didn't seem to be a limiting factor at all. And once patients were enrolled, patients were quite compliant with their subcutaneous injections, whether it be every 2 to 4 weeks. I think the fact that these agents are well tolerated is very pleasing, and I think that these agents, particularly in patients with established coronary disease, are very, very exciting. Now, as I mentioned, I think there were too many studies over the course of the last 12 months to choose from. I was very pleased that one of my colleagues spoke about the Paradigm HF study, looking at the neprilysin inhibitor and valsartan versus enalapril. I think There's continuing data on the role of atrial fibrillation ablation in a number of different clinical settings. And I think there's certainly more to come over the next 6 to 12 months. We're going to have more robust clinical outcome data from the PCSK9 inhibitors. Professor Weir was talking up the SPRINT study yesterday at the American Heart Association meeting later this year. And as my colleague Dr. Bagwardine mentioned yesterday, there are newer transcatheter valves coming to the clinical realm that we'll see emerging data on over the next 12 months also. So with that in mind, hopefully that will be enough to get me an invitation back next year to talk about the clinical studies over the next 12 months. So I'd like to stop there because I know we are running a little bit behind time, but also allows the opportunity for any questions if there are any. So thank you very much for your attention.